Good afternoon, ladies and gentlemen, respected chairperson. And I'm delighted to be here. Thanks to Dr. Amit Gupta, Dr. Bangshi Shabu for inviting me in this particular occasion. And I think I'm lucky enough to have another 2 minutes from Dr. Abha Gupta because she has completed 2.5 minutes prior to her scheduled time. Anyway, I'll be talking on women with diabetes, pre-diabetes effect of pre-diabetes on women. Uh, that pre-diabetes is not just a silent bystander. It is a sleeping volcano that can give rise to any sort of catastrophe. Usually, the pre-diabetes, the course is it can revert back to normal glycemia. It can remain status quo for a pretty long time, usually in the elder women, and it can either propagate to subsequent diabetes mellitus, any form, or in any time it can explode to any sort of cardiovascular or cerebrovascular disorder. The problem is that the prevalence of pre-diabetes is increasing throughout the world. If you can see this global burden of disease study, Lancet 214, the pre-diabetes, as you can see here, right from the ages of 20, it goes up. Female predominates. Even obesity and diabesity also predominates. And as per the last study of India 2017-2018, both diabetes, obesity at least 1.5 higher than men, except the diabetes mellitus, which is usually lower in women. That emphasizes the close link between obesity and diabetes. Even if you look at the incidence of pre-diabetes within India, as per the ICMR in the study, is 11.4%, diabetes 15.3%. And if you look at the South region, consider very recent meta-analysis published in January 2025, the incidence of prevalence of pre-diabetes is 8.56 and the diabetes 18.99. So having all sort of protection of genetic protection, hormonal protection, all those good factors, segregation of the subcutaneous fat to primary gluteal giving rise to gynoid obesity, and very less amount of visceral obesity, and the important pathway estrogen effect to mTOR pathway that is responsible for suppression of autophagy and inflammation and enhancing the other complications, adipogenesis, etc. But the thing is that having all this good virtue in a woman, right from the increased SPXs, that is a little bit negativity, but ARC in the aqueous complex in the hypothalamus, they have got the multiple effect of POMC. So appetite is less compared to men. Increased amount of fat mass, so adaptive thermogenesis is much more. They do have the more amount of peripheral insulin sensitivity. Their hepatic insulin sensitivity much more. That's why in premenstrual female, when it see fasting blood sugar, it usually remains low. So as HbA1c remains low, but always you need to have the 2 hours OGTT. Why the change from being protected to predisposed? Because of all these factors, socioeconomic, gender discrimination, maternal nutrition, hedonic energy intake, physical activity in a predisposed woman can lead to all this obesity, insulin resistance, pre-diabetes, and so and so. And including the past studies, insulin resistant pre-diabetes associated with excess androgen excess in production and low sex hormone binding protein, high testosterone usually linked with hepatic visceral adiposis, and ultimately coming to the PL or ApoC with more amount of visceral obesity, central and visceral adiposity, increased leptin incidence, IGT, type 2 diabetes, MASH and MASL, whatever you call, androgen and evolution, PCOS, etc. So looking at the pathogenesis of pre-diabetes, all this RAS stimulation, but recently vesicle propagation from cell to cell, trafficking of abnormal or dangerous microRNAs is one of the factors. You can find the microRNA which are very specific for pre-diabetes also. And second is most important is gut microbiome. Abnormal gut microbiome can lead to insulin resistance. It can lead to renal impairment early possible. And the most important one, abnormal amount of sodium is being absorbed, excess sodium SGLT2 expression in the renal tubules, and all sort of sodium entry mechanism increased by hyperinsulinemia, leading to even in endothelial cells, because of the innate activity, more amount of sodium goes inside the hole. It can ultimately lead to reduced endothelial nitric oxide synthesis production and leading to all sort of vascular abnormality. So looking at the impact, hormonal altered estrogen, androgen, subcutaneous adipose tissue convert into visceral adipose tissue, and all sort of central obesity, reduce BAT and thermogenesis. You know, adaptive thermogenesis is the only condition where the women are usually resilient in a very cold atmosphere. That is also responsible for non-exercise energy expenditure, which is not present in male. So menstrual irregularity, PCOS, all infertility, reduced fecundity. In a US study, the reduction of fecundity even up to 18% was located. GDM, preterm birth, all this sort of metabolic, visceral adiposity. Individual muscle with PD has 2.5-fold higher risk progressing to type 2 diabetes. The hepatokine, this is the important hormone, 15A, that is responsible for inhibition of tyrosine kinase. That's the only one of the very important insulin receptor. So leading to all sorts of muscle. Then women with pre-diabetes and diabetes had shown to have greater relative differences in all the parameters of metabolic syndrome, like waist circumferences, high CRP, increased triglyceride level, all statistically very much important. Then your vascular excessive salt absorption throughout the renal tubules, endothelial sodium entry, diffuse vasculopathy with high risk for cardiovascular disease and CKD, albumin and other microvascular disorders, hypertension. Ladies with prediabetes may develop resistant hypertension. That is very much important. Then coronary heart disease, increased heart failure incidences, ischemic cardiomyopathy. It can lead to also non-ischemic cardiomyopathy. Then peripheral artery disease. These are all subsequent reports, but very important report, as you can see for the latest atherosclerosis plus published in 23, that US cohort, all the people admitted between 2018 to 2020, they have been analyzed to find that all the odds ratios are increased right from the acute ischemic stroke, acute heart failure, and cardiovascular disease. These are all increased in pre-diabetes. Many times, different strategies are also there. Studies also found that there is no difference between pre-diabetes and diabetes in women compared to men. But this particular study has proved that pre-diabetes is very much important factor to develop all sort of cardiovascular disorder. So again, you have got the high pituitary adrenal axis in females and increased central insulin resistance. This can all lead to increased stress, depression, and anxiety in female pre-diabetics. And there is some relation to the report of cancer in different studies, I can say. Colorectal, stomach and colorectal cancer, pancreatic cancer, but these studies find no difference in breast cancer in pre-diabetes. So ladies and gentlemen, pathogenesis, progress, presentation, and CV risks are different, so should be the clinical and preventive research. To diagnose, rely on OGTT and A1C, not on fasting blood sugar. Routine screening with OGTT in all Indian ladies, at least above 12 years, is advisable, subject to decision of the leading authorities in India. So preventive childhood and young female diabetes should aim to establish a gender priority in all research activity. We do have lagging in female inclusion in different research. That is universally accepted. So ladies and gentlemen, thanks for the patient hearing.